Hello, my name's Andrew Brudbelt. I'm a neurosurgeon here at the Walton Centre. What I'd like to talk about today is the brain optimisation pathway. Traditionally, patients who have a brain tumour will present through the accident and emergency departments. Many of these will be admitted locally. They will sit on a ward for many days whilst they have a number of scans and tests done under a general medical team who may know little about their underlying diagnosis. They're then referred into the neurosurgical services and at some point seen by a neurosurgeon who can then talk through the different treatment options. That can take some time and it can lead to patients having extended periods in hospital and sometimes delays in the system as communication between the distal hospital and the neurosurgical centre is not always as smooth as one would like. The point behind the brain optimisation pathway is to try and minimise that, to describe who takes responsibility for the different parts of the pathway to get patients home quicker, get their investigations quicker, and get them to see somebody who understands what their different options are to talk about those options with them. So the brain optimisation pathway was introduced by one of the local hospitals, and we've worked with them and we're now starting to try and roll this out within the region. The idea is that the initial management of patients involves rapid assessment in the A&E department and referral on to the appropriate person in the hospital who can manage that initial assessment and investigation process, be that the palliative care team, the acute oncologists or the general physicians. That in most cases will involve getting an MR scan done of the brain, and it may involve CT scanning of the chest, abdomen and pelvis. Many of these things can be done as an outpatient, but it needs somebody coordinating that to make sure it happens effectively. Once that information is known, then where patients go from there depends a bit on what is thought to be the underlying diagnosis. If it is a primary malignant disease, then the patient would be referred and seen in at the Walton Centre, and we would be able to chat to the patient about the implications of this, whether treatment is available, an option, what that treatment would be, and the timescale for that. And we can then help with the management of symptoms and drug treatment. If the patient has metastatic disease, where they have cancer that's spread from other parts of the body, then the pathway is slightly different, in that many patients who have cancer will develop metastases to the brain. And in fact, only a very few will ever need neurosurgical or focal type treatments. Most patients can be treated by their own oncologists if they warrant treatment. So many of the metastatic patients don't need to wait to be discussed in a neuro-MDT or to see a neurosurgeon. They can be managed by their own clinical oncologists. And this pathway is to try and help move them in that direction more quickly. So for example, patient with breast cancer who presents with unsteadiness and has imaging evidence of a lesion in the back of their brain can be referred to the neurosurgeons. We cannot assess if surgery will help without knowing a number of other things about this patient first. We need to know the extent of the disease. We need to know how well they are. And if we can have all that information, it makes it for a much more efficient discussion, and we can then look at the best effective treatment. For patients with primary malignant disease, as in this patient here who has a glioblastoma, the pathway allows us to accept that the neurosurgeons take responsibility, whether we feel they have a treatment option or not. We can see them in the outpatient clinic, we can discuss with them what those options are and what the reality of the situation is and what that means for the patient, so they can help plan what they're going to have done or what symptoms they may develop in the future. So even though pathways and brain optimisation pathway doesn't have a nice snappy title and may not be seen as something very interesting, for patients this can potentially make a lot of difference in keeping people at home while they're having the investigations done. The investigations are done more quickly and they get to see the right person who understands what their treatment options are sooner rather than later.